Welcome to Audioboards. Today we're dissecting one of the most high-stakes, heart-racing pages you will get as an internal medicine resident on call. Rapid response called for: acute respiratory distress. Picture it. You're running down the hallway, the cardiac monitor is beeping in the background, and the nursing staff is gathered right outside the door. Your heart rate is 110. In that moment, the single most important mindset shift you need to make is simple. Do not fixate on making a diagnosis in the first 30 seconds. Fixate entirely on the patient's stability. The moment your feet cross that threshold, you perform a rapid 10-second visual assessment across 3 key domains. First, mental status. Are they alert and anxious, or are they lethargic? Somnolence in acute distress is hypercapnia or respiratory muscle exhaustion until proven otherwise. Second, work of breathing. Look for nasal flaring, intercostal retractions, tripoding, cyanosis, or single-word speech. Third, airway protection. Are they pooling secretions, coughing effectively, or exhibiting a completely silent airway? If your patient has a GCS under 8, is obtunded despite low oxygen saturations, or is completely exhausted trying to blow off CO2, stop waiting. Call for a stat intubation tray and notify your ICU senior or fellow immediately. If they are conscious and protecting their airway but still struggling, you need to systematically step up the oxygen escalation ladder. If they're saturating poorly on a standard nasal cannula, your immediate temporizing move is a non-rebreather mask at 15 liters, delivering 100% FiO2. If their PaO2 remains below 60 millimeters of mercury despite the non-rebreather, transition quickly to high-flow nasal cannula, which gives you precise FiO2 and up to 60 liters of heated, humidified flow. If you suspect hypercapnic ventilatory failure, like a severe COPD or asthma exacerbation with a PaCO2 over 45, BiPAP is your gold standard to blow off CO2 and rest those tired respiratory muscles. If it's acute flash pulmonary edema, CPAP is fantastic because that continuous positive pressure reduces preload and transmural LV wall stress. But keep your red flags for intubation in mind. APH below 7.25, meaning they will tire out trying to blow off CO2, worsening hypercapnia despite non-invasive ventilation, altered mental status, or unmanageable secretions mean it's time to intubate. Here's a crucial clinical pearl before you move on. Always check for an artificial airway first. If a patient with a tracheostomy or endotracheal tube suddenly decompensates, treat it as an airway rapid response and assume a mucus plug or dislodgement. Pass a suction catheter immediately. If it won't pass, remove the inner cannula or replace the tube. While you're stabilizing the airway and getting oxygen on board, have your co-resident or nurse quickly pull up the EMR to gather the intake summary and answer 4 vital questions. What were the acute complaint and hospital day events? What was the admission reason and what happened today? Did they just get 3 liters of IV fluids in the ED? Or did they have a procedure like an EGD an hour ago that puts them at high risk for aspiration? What is their baseline oxygen requirement and acuity of change? Are they normally on room air, or do they live on 2 liters at baseline? How fast did this develop? What are their relevant comorbidities and code status? You must confirm code status, specifically DNI, do not intubate, and identify the surrogate decision maker before you start prepping induction agents. And finally, what is their current access? Do we have solid peripheral IVs, a midline, or a central line for pressors and medications? Now, you put your stethoscope on their chest to evaluate their vitals, oxygenation, hemodynamics, and physical findings. If you hear diffuse wheezing, think bronchospasm from COPD or asthma, anaphylaxis, or cardiac asthma, and get duonebs and IV steroids started. If you hear bilateral crackles or rales, think cardiogenic pulmonary edema, ARDS, or pneumonia, and prep IV furosemide alongside CPAP or BiPAP. If you find unilaterally absent breath sounds, you're looking at a potential pneumothorax, a foreign body or mucus plug, or a massive pleural effusion. If you hear stridor or upper airway noise, suspect anaphylaxis, laryngeal edema, or a foreign body. Give IM epinephrine 1 to 1000 at 0.3 to 0.5 milligrams every 5 to 15 minutes as needed and prep for an emergent airway. And if you see elevated JVP alongside peripheral edema, volume overload from right or left heart failure is your main target, so reach for diuresis and nitrates. While waiting for a stat chest X-ray, pull out your ultrasound. Point-of-care ultrasound, POCUS, is your absolute superpower during a rapid response. Look for B-lines, Diffuse bilateral comet tail artifacts indicate alveolar interstitial syndrome, usually pointing to flash pulmonary edema or ARDS. Look for lung sliding. A lack of sliding on M mode confirms a pneumothorax. Look at the heart for RV strain, like McConnell's sign or a D-shaped LV. In a hypoxic, hypotensive patient, that strongly points to a massive pulmonary embolism or severe pulmonary hypertension. And check the IVC. A plump, non-collapsible IVC means volume overload or elevated CVP, while a flat IVC points toward hypovolemia or sepsis. At the same time, call out for the rapid response rainbow of stat diagnostic orders, a stat ABG or VBG to differentiate acute hypoxemic versus hypercapnic failure and evaluate pH, PaO2, PaCO2, and lactate. A bedside stat CXR to identify infiltrates like pneumonia or aspiration, edema from CHF, lobar collapse or atelectasis from plugging, or a pneumothorax. A 12-lead EKG to rule out acute ACS and ST elevation MI, or new arrhythmias like rapid AFib driving acute heart failure if they have chest pain or an unclear etiology. And a full panel of labs including a CBC, CMP, lactate, troponin, and NT-proBNP. Once you have your clinical picture, your targeted action plan will divide into two major physiological buckets, plus a few special life-threatening scenarios. First, hypoxemic failure, where PaO2 is under 60. For acute pulmonary edema or flash edema, hit them with high-dose IV loop diuretics, usually double their home oral dose, add sublingual or IV nitroglycerin or nitropress if they are hypertensive, and put them on CPAP or NIPPV. For pneumonia or aspiration, start empiric broad-spectrum coverage like cefepime and vancomycin, add anaerobic coverage if there was overt aspiration, and support them on high-flow nasal cannula. For massive mucus plugging and lobar collapse, order aggressive inline suctioning, chest CPT, nebulized hypertonic saline or acetylcysteine, and get pulmonology on the line early for a bedside therapeutic bronchoscopy. For a pneumothorax, if they are hemodynamically unstable, perform immediate needle decompression at the second intercostal space midclavicular line or fifth space anterior axillary line before thoracic surgery arrives to place a chest tube. For a pulmonary embolism, if they're stable, confirm with a stat CT pulmonary angiogram. If suspicion is high and there are no contraindications, start a heparin drip or Lovenox right away. If they're unstable, consider bedside thrombolytic TPA or activate your PERT team. For pulmonary hypertension, if it's a known PHTN patient, call the PHTN team immediately, give gentle fluid resuscitation, and order an echo. And for a pleural effusion, manage with diuresis and perform a bedside thoracentesis once stabilized. Second, hypercapnic or ventilatory failure, where PaCO2 is elevated. For a COPD or asthma exacerbation, give continuous duonebs, IV methylprednisolone at 125 mg or oral prednisone at 40 to 60 mg. Add antibiotics if indicated and initiate BiPAP early. For opioid toxicity, titrate low-dose IV naloxone from 0.04 to 0.4 mg, repeating every 2 minutes based on response, carefully restoring their respiratory drive without throwing them into acute, violent withdrawal. For altered mental status or acute stroke, call a stroke alert and order an emergency non-contrast head CT. And for severe acidosis from sepsis or DKA leading to respiratory muscle fatigue, treat the underlying cause, consider bicarbonate, and prepare for early intubation as their muscles exhaust. Finally, keep an eye out for these other life-threatening presentations. For massive hemoptysis, defined as over 30 milliliters, remember this critical rule. Patients rarely die from blood loss in pulmonary hemoptysis. They die from asphyxiation. If it's minimal under 30 milliliters, observe closely. But if it's massive, suction immediately. Position the patient with the bleeding side down to protect the healthy, non-bleeding lung. If they aren't protecting their airway, intubate immediately and correct any coagulopathy with transfusions. Call emergent pulmonology for bedside bronchoscopy with balloon tamponade or electrocautery and interventional radiology for bronchial artery embolization, considering a CTA to localize if stable. For anaphylaxis, administer IM epinephrine 1 to 1000 at 0.3 to 0.5 mg every 5 to 15 minutes as needed, along with IV Benadryl, albuterol nebulizers, and IV methylprednisolone. For acute coronary syndrome, or MI, load with aspirin 325 mg, atorvastatin 80 mg, sublingual nitrates, a heparin drip, and beta blockers if they aren't in cardiogenic shock. And for a panic attack or acute anxiety, provide reassurance and PRN benzodiazepines once you've officially ruled out organic life threats. To wrap everything up, keep these 5 golden rules in your pocket for every rapid call. Assess airway instability first. If they can't speak or protect their airway, stop reading the chart and prepare for intubation. Escalate oxygen systematically. Non-rebreather to high flow to BiPAP or CPAP to intubation. POCUS is your superpower. Check for B-lines, lung sliding, and RV strain in under 2 minutes. Know the code status early. Confirm DNI status before prepping invasive interventions. Positioning matters. If it's flash pulmonary edema, sit them straight up. If it's massive hemoptysis, put the bad lung down. Thanks for listening to Audioboards. Stay tuned for more educational content in our next episode. The views and opinions expressed on the Audioboards podcast do not necessarily reflect those of our employers. This podcast is for educational purposes only and should not be used to diagnose or treat any medical conditions. It is not a substitute for professional medical advice. Always consult a qualified, board-certified healthcare provider for any medical concern.